From the plains to the rolling hills, Oklahoma is a state that resonates with stories of resilience, determination, and pride. Welcome to Inside the 1581, a podcast of the Oklahoma Hospital Association. Together, we'll dive deep into the heartbeat of the great state of Oklahoma as we journey through the rich history, diverse culture, and the ever-evolving landscape within the 1,581 miles of border in our nation's 20th largest state. Each episode of Inside the 1581 will feature conversations with the many voices which help shape our state's future and our shared vision of improving health and healthcare in Oklahoma.
Thank you for joining us for this edition of Inside the 1581. This is our Voices segment, and you've heard from a couple other healthcare leaders as we've spent some time interviewing, not really interviewing, talking to healthcare leaders in our state as part of our Connect conference. And our Connect conference is really an opportunity for members of the Oklahoma Hospital Association, our policymakers, our vendor community, really to come together and better understand what our needs are and understand our vision for improving health and healthcare in Oklahoma. And so we've been having these conversations in the convention center here, so it's a little noisy, but I'm delighted to have joining us our vice chair of the board of the Oklahoma Hospital Association, and Bennett Geister is the president of the Oklahoma City's Communities for Mercy Health. And Bennett, we're glad to have you joining us today. And I know you've spent your whole career, in fact, you were in Oklahoma City for a while, then we're in Tulsa, and now you're back home. I bet your parents like that.
They love it.
Your kids get to see grandma and grandpa,
they do.
While you're here, which is a good thing. And but you've had a great career as young as you are. For some of our folks to know who is Bennett Geister and to know what it was that called you into this vocation. Because I was chatting with Denise. I believe that people who work in healthcare aren't in this to punch a clock. They're in this because they've been called to serve or to minister or to help their neighbors. And I'm sure you probably have a similar feeling in that regard. So tell us a little bit about Bennett and what got you into this.
You bet. I guess I would start by saying I'm a father and of four beautiful kids. My oldest is 7 years old. My youngest just turned 7 months.
And you wear glasses that cover the tiredness, right?
That's exactly right.
I know I did.
The
I have
bags
three,
underneath my eyes.
Yes, exactly.
And then a proud husband to my wife, Kelsey, who works way harder than I do.
She's a great Thunder fan.
And she's
I saw her yesterday having a good time at the game. Yeah.
So that's the most important thing. I think wanting to be faithful to the call, because I think to your point, Rich, all of us who want to be in healthcare, one of the underlying foundational things we tend to agree on is that there was something that called us into it. Right. And so having her and having my kids, that keeps me grounded with all the change that has happened in our lives throughout my career, within our family as our family has grown. That's where I have to start. In terms of my career, I would say my dad played a huge role in it. My dad's a medical oncologist. So, growing up, I was one of three boys, the oldest of three brothers. Watching Dad come home, seeing how he was able to pour himself into us after pouring himself into cancer patients.
So he's a dad and a healer.
That's exactly
think
right.
About it, yeah.
And, I watched him. I saw the strength that he had. I'd get up early in the mornings before he'd go in and round at the hospital. Right. He'd always come around our circle drive. He would wave at me, and I would wave back at him from our front door. And I'll never forget those moments. And then he would always make it to our game somehow, even though he was seeing inpatients rounding in the morning, and then going to clinic and seeing patients in clinic, having to go back to the hospital later in the evening and go handle admits and things of that nature. He found ways to get our family together and to be dad. And so watching him growing up, I knew I didn't want to be a doctor, but I saw myself being able to support the people who are directly giving care to our patients. And he was a huge inspiration to that.
Well, you're telling this story, and it did bring me back. Yesterday, we had Johnny Bench speak to us, and an Oklahoma-born Binger boy, as he would say. And I had to go back and look at that quote that he said, and I think this is, an example of your dad aspiring to inspire.
Absolutely.
Before you expire. So, I mean, your dad spent and dedicated his life to being an aspiring father and to inspire you and your
Without
brothers.
a doubt.
And that's magical when you have that.
Oh, it's been hugely impactful. And so he always joked with me, he's like, whenever I said I wanted to go into hospital administration, what he won't say is largely he was the one who suggested maybe you should look at hospital administration.
Right,
but when I finally made the commitment, my dad and my brother, Brandon is an internal medicine doctor, they love to joke, hey, you went to the dark side.
Well, what you did is you just recognized that you weren't as good in organic chemistry as they were. I think that's what kicks everybody out, when you have to take those classes.
Absolutely.
So you serve as the vice chair of OHA, and you've been involved in the association for a while, and I'm sure you have seen our state grow, mature. If you looked at the state of healthcare today in Oklahoma, what would you have to say? What would be your response to that if you asked that question?
You bet. I would take it two ways. I think one is as a provider, and I think it is the second one is as a sort of community member. So I'm optimistic. As a provider, I'm really optimistic. I think our association right now, as a hospital association, is as strong as we have been on my time on the board. And I would say probably beyond that. I mean, we are really, really unified in what we're trying to do collectively to bring value to consumers here in the state of Oklahoma and to take care of our communities more effectively. And so a lot of work going into our grant process, how we're raising money, how we are working with our legislators and elected officials to drive important changes that are going to help impact our communities economically, and help us have the resources we need to continue to drive value to the people that we get to serve. That's something I'm optimistic about. And I think, we do a good job of sort of balancing the needs of our more urban areas versus those of our rural areas. And so being able to recognize those needs, talk about those needs freely as a board, and OHA Connect, what we're here right now, it's a big deal, and it's driven by relationships and trust. And so as I think about alignment from healthcare providers over the next several periods, years, however you want to look at that, I'm optimistic. I would be remiss if I didn't say that, from a community member, we still have a lot of work to do. I mean, our health status here in the state is in the bottom 3, so we haven't made a lot of progress there. And so we still have work to do when it comes to education, when it comes to access, when it comes to working with key community leaders and organizations in influencing consumer behavior in a more positive direction. Those are things we have to continue to focus on, but we're making progress, and I think the framework is in place for us to make a lot of progress in a good near-term period of time.
Well, when I look at Mercy, you've got a pretty large footprint. I mean, the system's in a number of states. You're a mission-driven, faith-based organization, and jump in me if I misstate anything.
Yeah, please.
And you've got hospitals really kind of spread from the northwest almost down to the southeast corner.
Absolutely.
You've got critical access hospitals represented in your system, and in our previous episode we kind of talked a little bit about what are critical access hospitals, and we had Trent Borland chatting with us. So if you look at what you're doing across the state, is there any takeaways from how communities should view hospitals being good community partners?
Man, that's a great question. Yeah, a little bit more on Mercy as an organization. 31 hospitals spread over 4 states, but our ministry extends far beyond that. And a lot of the work that the Sisters of Mercy are doing to impact the communities that we serve. And so what's really cool about that is 55,000 caregivers taking care of all these various communities. And so we get to learn from one another and what's working.
So you build those best practices that might be working in Missouri, you bring it here?
Absolutely. And we're unlike some organizations, we're geographically centric enough where it's easy to gather and it's easy to share those practices. It's easy to roll out framework because there's not a lot. There's some, but there's not a lot of geographic, variation between Oklahoma, Missouri, Arkansas, Kansas. And so kind of being right there, a lot of what works in one community oftentimes works in another. The thing that I've been impressed with in the time I've been with this organization is we've really gotten aggressive on population health. And
that's important because we heard Paul Keckley talk about that
absolutely.
today, that convergence between, social delivery, social needs, and our ability to ministry or heal people.
It's somebody newer into the organization, Rich. What's fascinating to me is, Mercy is looking at what a lot of organizations I've worked for in the past I would consider these to be soft costs, things like length of stay, things like medication management. These are things that as part of a value-based contract, you're worried about it as an operator because oftentimes these contracts, Medicare Advantage contracts, Medicare ACO, et cetera, they're going to pay us for work we did a year plus ago this year. And so we have to take some chances on how do we accrue, and not to get like super finance nerdy here, but how do we accrue and do we have the confidence in what we're doing to deliver value so that when that settles up a year from now, we know that we've earned those dollars that we've been accruing for. And so we look at that as a ministry as hard costs. And so, how are we managing our heart failure patients? Are we getting our heart failure patients to lower settings, lower acuity settings of care in order to avoid a massively expensive, long hospitalization because their heart failure got out of control.
Sure.
Now we're having to diurese them in the ER, put them in a bed. And who wants to be in a hospital bed, right? And the risks to a comorbid patient go way up when they're hospitalized because we know that their likelihood of getting a pressure ulcer, having a hospital-acquired infection, falling and having a hip fracture, all those things go up. And so how do we make sure we keep our patients in the appropriate care settings? And it's both a blessing and it's a curse. The blessing is there are Medicare Advantage is one. There are opportunities to do well in that field, but the challenge is that's a delayed gratification. And so you really have to jump in terms of dedicating the resources to set you up appropriately. And it's a lot easier said than done. And so I'm still learning in that in terms of Mercy.
It's incredibly complicated too. I mean, and you're dealing with, patient behaviors.
Absolutely.
How do you adjust for that? So if you're working with a patient, certainly that they need to make a significant dietary change, but they're not willing to do that. But we still treat them and we still make sure that they have, all of the access to the services, even though we know they're not, following doctors, medical advice.
Absolutely.
But, Bennett, when I'm listening to you, I'm thinking, there's stories to be told.
Yeah.
And I think as hospitals and we don't always tell a very good stories about the real meaningful work that we do. Mm-hmm. And I'm sure in Mercy, you've seen some real meaningful work that you probably would acknowledge, gosh, we need to do a better job of the public understanding that and understanding our community benefit and each of us our promise to our community. Are there examples of some of those that you might be able to roll off your tongue that folks would find, wow, I didn't know that?
Absolutely. I mean, I would start by starting with quoting our mission statement. It says, as the sisters of mercy before us, we bring the healing ministry of Jesus, ... basically to everything that we do. And so I think that permeates through the entire organization. The first thing I think about the top of my head is, and again, for the listening audience, I don't want to get way into the weeds here, but 340B, it's a drug discount program that's designed for us to be able to provide high-cost medications to the least of these that we serve in our population. And that was what it was designed to do. There's a lot of scrutiny on that right now, but we have chosen to take a lot of those funds, millions of dollars of what we're getting through that program, and we're putting them right back into homelessness here in our community, the food bank, transitional care to help people who are underserved, less privileged, to be able to get resources that they need We have a board and a committee that is sitting there looking at how can we give back what's been given to us and what we've been blessed with. And, that's not something that we necessarily go out and boast about. We probably should, Rich, honestly, because that's one of about 5 things I could just start rattling off in terms of what we're doing for community benefit.
Well, and for you all, you have a very large retail pharmacy operation too. So, making that care available closer to patients is important. And you're right, on 340B, again, it's healthcare jargon, but you're right, it is simply our ability to deliver lower cost medications to our patients.
Absolutely. I think community benefit, another one that comes to my mind is, in most of our rural communities, your 2 largest employers are your hospital and your school.
Right.
And if either of those 2 employers are in trouble, that community is in trouble. A lot of people, particularly people in the city, we don't understand that. If you grew up in Oklahoma City or Tulsa, you don't necessarily understand that. But those 2 businesses are the lifeblood to the economy in our rural markets and communities. And so how do we make sure we're able to support, at least within our network, and then frankly beyond that, our rural hospitals? And so, that's where our ability to work really collaboratively with our critical access hospitals in Watauga and Kingfisher and Guthrie to get the right patients in those healthcare settings, that is helping those hospitals provide a very necessary need in keeping those community members in their local communities next to their family and friends. And so those are things, care coordination is probably the way I would button that up. But those are the things that are so utterly important to us as healthcare leaders, and the way we're driving and leading those efforts in order to bring a product that the people we serve find to be adequate and ideally far exceeding expectations.
Sure. When we all talk about the importance of rural health, I am reminded of the story of early map makers. They were called cartographers, and during the early days of map making, you would have a cartographer would draw his map or her map, and then it'd be out there. People know where they're going. Well, then those maps would be updated. Well, the next year, if somebody drew a map, they might copy somebody else's map, right? We didn't have copyright laws in the early days. And so early cartographers, what they would do is they would make up the name of a town. They'd be called a paper town because they only appeared on paper. And so for me, I think of our small towns is that if you lose your hospital, you're really heading down that track of becoming a paper town, a name only on
Absolutely.
a map. And so we need to do that. And I do appreciate, our members, and I know Mercy, you all have, serving rural communities as well. And it's important. And in those communities, and I think you referenced it, about the economic impact. If you look at Mercy's economic impact on our state, let's just maybe look at the Oklahoma City communities. Any information you can share with us in terms of, what you're spending in the community, the number of employees you have? Because we heard today, we were reminded today when Paul Keckley said that on average, a healthcare worker in Oklahoma makes 27% more than the next person because of all of the skills and the trades and investment we make in them.
Yeah, I think the easiest way, the way I like to look at in terms of economic impact is we have just within the Oklahoma City communities about 4,500 caregivers that are employed and taking care of their family and friends. Across our state, we're probably a little bit over 6,000. So, I think we do play a significant impact. You think about the multiplier on then all of those people who trust Mercy to be able to take care of their families so that they can live and thrive in abundance in their communities. Those people are then going out, they're supporting local businesses within their communities. They are eating out, they're buying from their local grocery stores, and everybody wins in that type of model. And so we could start getting into some really nebulous stats that we love to talk about, but I'm sure our listening audience wouldn't be as interested on. But I think that's the big one. It's 4,500 caregivers in a variety of care settings: clinics, specialty clinics, primary care. We've got 3 hospital-based facilities, including Mercy Hospital, our South location on I-240 and Sooner, our Edmond location on I-35 off of between 33rd and 15th. Those are all areas where we're able to provide health care geographically, hopefully convenient to a large population of our patients just here in this community.
Well, I know as a patient of Mercy. I had my surgical procedure, great outcome, great medical staff. I can attest, and my wife, who is in the Norman Health System, she loves her nurse practitioner, and so we're kind of like divided family here. We got lots of members, 137 hospitals in the membership. My wife and I picked 2 different members for their care. Yeah, so it works for us. We're here and we're spending time with our colleagues, and we're learning as we're going through this. As you've seen in your career, and certainly you have been in settings where you're listening from real thought leaders.
Yeah.
If you look at what might be, from your perspective, the biggest challenge in healthcare, what would you say is that biggest challenge?
That's tough.
I'll give you some examples.
Yeah.
We heard workforce.
Yeah.
I mean, Denise spent a lot of time talking about workforce, and I think Trent spent some time too talking about very specific needs for rural, but I think he also referenced workforce as well.
Right. I would say, okay, so yes, that's always. I mean, that demand as our baby boomers continue to age, as we are trying to get more and more people into the industry, whether that's doctors, nurses, techs,
Right.
EBS technicians, food nutrition services.
Or even the business office.
Revenue cycle. I mean, yes, that's always a top 3 challenge, undoubtedly. I'll do a little bit more philosophical.
Okay.
I would say we have a foot in 2 worlds right now, and you have to do both well. I've got 1 foot in, I need to provide better access, more timely care, in a way that consumers just nowadays expect. Okay, so if I can get on my phone right now and order something off of Amazon and have it delivered to my front door in the next 24 hours, how do we make healthcare access more convenient, more on our patients' time, on our consumers' time? Because that's what they're asking for. That's what we see everything going. That's tough, because then what that means is I've got to have more resources dedicated to opening up templates, to being able to provide extended hours, those types of things, so I can meet patients more on their timetable. At the same time, I've got a foot in this other camp, which is how do we manage value? How do we derive value? How do we improve outcomes? How do we message that with wisdom and with tact and with grace to the people who are doing the work? Because in a sense, we're asking them on one hand, hey, we need you to see more patients. Our consumers, this is what they expect. This is what they desire. And here's some resources to help you do that. On the other hand, we're looking at it and saying, hey, we need you to hit these measures, all these measures that are tied to these contracts, so that we can get more resources derived from value, so that we can reinvest them back into you and the organization. And I think that message, and then
and you have generations that have expectations for how they receive healthcare. So, we look at seniors are going to need more personalized,
without
in
a doubt.
person, and
Without a
and our kids are going to be like, hey, let me just talk to my watch.
That's it. I mean, I laugh
different.
even with our kids. It's like one of my kids, Baker's got fever. I'm pretty sure he has an ear infection. I walk up, I smell his ear. Yep, he's got an ear infection. We have 4 of them. They get ear infections all the time.
Yeah.
I don't need to go in and see the doctor to get my amoxicillin so that I can give it to Baker. I want easy button. Can I shoot a text message? Can I get on to, Epic Chat and message my provider? And are they going to require me to have to come into the office, or can they just order the amoxicillin? And they're gifted in that arena, and they do such a great job of that naturally when they think about how they care for their patients. Versus, my grandmother, when she needs to go see the physician, she is going to go into their physician.
Right.
She expects that. She expects to have a face-to-face encounter with her physician. And so we are still going to strive to be all things to all people. But again, back to how do we educate and work with our community partners, and best practices shared across all of our hospitals, whether that's within Mercy or across the association, to drive value, and in a way that our consumers expect, but also understand as we sort of navigate across this crevasse.
It's when you think about it, there's a lot of opportunity to kind of unwind the traditional care models as we go forward.
Absolutely.
So do our seniors start with the geriatrician first? Someone's focusing in geriatric medicine first, where it might make a lot of sense for nurse practitioners or others to manage some of the routine follow-up that the physician can now avail herself or himself to taking on the next patient. I mean,
Without a doubt.
we've got to figure that part out because there's only so many bodies.
No doubt.
And I'm much older than you are, and I'm going to be consuming more healthcare here quicker. And so we have to make sure we plan for folks like mine, the very last year, the baby boomers I am. And so we have this big push, and we've got to make sure that we have the resources, certainly, to deliver on our promise.
Without a doubt. Very well said. And I think, too, this is the hard part, when it comes to lawmaking, when it comes to how we're working with our elected officials, there's probably 10 decisions we're making every day where it's like, I'm thinking, man, this would be such an amazing solution for my hospitals and my rural communities. But, in Northwest Oklahoma City, the medical staff has a very different idea or expectation. And so, when we're trying to figure out that balance between standardization versus allowing individual communities to make the decision that's best for their communities, I think all organizations, all hospital systems, even standalone community hospitals, everybody's wrestling with this. What do we standardize to get efficiencies, to be more standard in our approach versus what is unique to my community so that I'm providing a service that exceeds my specific community's expectations. And, that's the blessing. That's the reason why associations like the OHA exist. I mean, it's for us to be able to gather, talk about what's common, figure out where we may be unique or where we may be able to share something we're doing that's unique that could drive value across the state of Oklahoma, and then replicating that so that we can look back and say, hey, we actually derived a material benefit to the people that we served because of the way that we come together to share these best practices like at OHA Connect 22.
Well, I didn't ask Trent or Denise this, and I'll ask you this, and
Sure.
We can kind of wrap after this, but I'm just kind of curious, when you went to business school, did you ever think you would work in a field that is so complicated, for which you have so many external forces that truly not only influence, but really drive the end, if we go back to business school, our end product or our deliverable, for here it's a service that is so complicated? Because I don't think people really appreciate in the role that you're in and your other senior leaders, how hard it is. You deliver, so you're talking
Sure.
value. So everyone has a different way they would define value, but you've got input costs that you don't have a lot of control over. You've got physicians and other extenders who operate independently.
Yeah.
You bring all of that together, and in the end, it comes out delivering a baby. In the end, it comes out with somebody having a successful surgery, or in the end, it comes out with somebody getting a good read on their CT. I mean, all of these things. That's the magic in what's done in healthcare. I don't think people really appreciate how complicated it is.
I joke, and I tell all of my orientation classes, if anybody asks me to talk about a leadership principle, I always love to joke. When I first started as an administrative resident, I remember I was asked to go into a meeting with the nephrologists.
Uh-huh.
And as you would expect, even though I have a master's degree to my name, the first thing I do is I pull out my phone, I Google what is a nephrologist, and I probably spelled it with an F. So, because we talk in a jargon. I had a doctor once tell me mastering medical terminology is the equivalent of learning 3 foreign languages.
Yeah.
And probably one of the biggest leaps I made from a leadership standpoint throughout my career was getting over the fact that I don't know, most of what I deal with on a day-to-day basis, there is somebody in the room that knows more about that particular subject than I do. I quit worrying about what I didn't know, and I started just being really open with, I have no idea, but you know what? I've got radiology, or I've got my physician leader, or whoever that is in the room that knows that I can lean upon.
Absolutely.
So that I become better, so I can make a more informed decision. And I think that's the inspiration. Even at the conference this week, I'm sitting here like, man, some of that stuff that, especially Dr. Keckley, I mean, what he was talking about, is just some of that stuff is over my head. I mean, it's really thoughtful, but it's very, very deep, and there's a lot to it. And so, hey, I can admit that, but I've got a lot of smart people around me that are helping us drive this so that I can be the very best person for the role that I play within my organization. again, that's a gift and a blessing for all of us.
Well, and I think for many of you, you're a chief people person. It's hard to say, there's a lot of P's in that. But it is, leadership does come with a recognition that we don't have to have the answers.
That's right.
And we have to be secure in that, and we lean on our people. And when you create a psychologically secure environment, people will speak up, and it gives you the freedom to ask questions because you don't know them.
Amen. Well said. Couldn't say better
important.
myself.
Well, listen, Bennett, thank you for joining
Thanks,
us.
Rich.
And for those of you listening in, this is our third installment of our Voices of Inside the 1581. We've been here at the Oklahoma Hospital Association's annual Connect conference here at the Convention Center. I think folks have had a really good time, and we look forward to being able to continue to bring our members together. As we close every episode, we talk about why we're here and what is our mission that calls us, and it is to improve health and healthcare in Oklahoma. And we appreciate y'all spending the time listening in. And Bennett, again, thanks for joining us.
Thank you so much, Rich.
We'll talk to you guys again soon.